Good morning, everybody. Let's start our day today with an arthroplasty session. Let me present to you Dr. Mansour Sadeki of French Border Orthopedic Surgery, specialty in lower limb orthopedic surgery, University of Paris. He's specialized in knee and hip arthroplasty, sports injuries, hip and knee and ankle arthroscopy. Thank you, Dr. Mansour. You can start.
صباح الخير. First of all, I would like to congratulate Dr. Uwaid Al-Mtairi, head of department, Jabr Hospital. As you all know, we launched our first robotic surgery at Jabr Hospital. We're really proud, and I think it's a way to go forward. بعدين الفلوس. Okay. So here we're going to talk about not how robotic arthroplasty is better or what are the advances about it and why do we prefer to do robotic arthroplasty. Here we're going to concentrate on one subject only: is it cost effective or not? Just to give you a brief about it, robotic arthroplasty, we use certain software to convert the anatomical images we have to a virtual three-dimensional reconstruction. So this technology will help us interpret deformities in the joint, sizes, to be able to do an arthroplasty with a better outcome. The anatomy usually is obtained, depending on the technology and the type of robot, either by CT scan or just sometimes by operative mapping, intraoperative mapping. So it is not intended currently to replace the surgeon, but rather to provide the assistance. What do I mean by this? The robot does not guide us. Currently, we guide the robot. We tell the robot, I want to do this size of cut, this degree of cut, the gap, I want it to be this size. So the robot is currently guided by the surgeon. Our main goal about this technology is to provide better outcomes for the patient and better results and better degrees of satisfaction. So why are we going forward with robotic surgery? There is three main goals. First one is to decrease the mistakes associated with bone cuts. As we all know, sometimes when you're doing cuts with the mechanical method, if the bone is osteoporotic, the cutting jigs can move, and which gives us not a perfect result. The other thing with deformed knees or patients with hypoplasia and the femoral condyles, we tend to have malalignment in the positioning of these prostheses. And I think the most important aspect is the balancing. The robot will be able to provide us a higher degree of balancing. So this technology, everybody believes it's new. Actually, it's not new. Actually, it's the same as navigated or computer-assisted arthroplasty. It's just one step forward. It's basically the main technology, the same type of captors, the balancing is the same, the way to do the cuts the same. It's just going one step ahead. So why do we go with robotic arthroplasty? Why are we promoting this? Why do we believe this is better than the mechanical method? We believe that it gives better clinical outcomes, although many papers still debate this subject, but we really believe that it gives us better clinical outcomes. It reduces iatrogenic bone cast and soft tissue damage. It gives better positioning of the implants, accurate balancing, controlling the tension of the ligament, soft tissue preservation, especially with the Mako, where it gives us guidance on where to stop while doing the cuts. It increases stability, it increases prosthesis lifespan, if the prosthesis is well balanced, if it's well positioned. Usually it gives us longer prosthesis lifespan. And the one that has been talking about, it decreases revision rates. So what's the downside about the robotic arthroplasty? All we know, it has a learning curve. You have to be accepting change. Many people usually, if they're comfortable in doing certain things for years, they are not willing to go to this robotic surgery. The other we know it gives us longer operative times. We know in the beginning, usually it goes to half an hour to 45 minutes. It might be as long if after certain cases. And the clinical outcomes, which I just said that we're still waiting for all the results. As we know, the robotic is a new technology that has been just a few years back. And the downsides of robotic arthroplasty, as we all know, is the price. It is expensive. So the cost. So I looked through in the internet, just looking at the price. This is not the price that we have in the Middle East. This is the price that I found in the United States. The price of the Stryker Mako, it's 1.5 million per robot. It has the 100,000 service cost for yearly contracts. This is just to do the maintenance. And for the extra disposable equipment, the captors, the drapes and everything, we're talking about $1,000 per case. Now, removing the implant is $4,000. I think this is, because we use, many people do not know, maybe we use exactly the same implants. The implants doesn't change. The only thing that changes is the way to do the arthroplasty itself. When we talk the other one that is we all know about is the ROSA. The ROSA is a little bit less expensive than the Mako. It's 1.3 million per robot, US dollars per robot. The service contract, I checked and I couldn't find their service contract, and even I contacted the people in Zimmer here, even the guys do not know exactly what is it, but I think it's about the same price as the one in Mako. For the disposable items, I found that it costs about 800 to 900 US dollars per case. So when we look at about the prices of the robot, they're about the same. And even Johnson & Johnson's robot, even Smith & Nephew's, they're about the same. Most of them are more than $1 million per robot. So is it cost effective? So to say that this thing is cost effective, we should, what we think, it should decrease the post-operative pain because it's a better way to do this procedure. It should decrease the requirements of analgesia. It should give us better hemoglobin levels as we do not have more cuts to do. Quicker restoration to autonomous state, shorter hospital stay, and better knee mobility and lower risk of revision. So now this is a paper that I looked at where they compared robotic versus manual total knee arthroplasty in high volume surgeons. So they compared from, let's say, from 2017 to 2019, 6 high-volume surgeons operated 2,392 mechanical versus 2,392 robotic. The robotic took longer. It took 139 minutes per case, while the mechanical took 107 minutes. And we know this. Robotic needs, there's more steps to be done, many more things, so it takes more time. The total cost per case was greater. It was 11,615 for the robotic and 8,674 per case. There wasn't any significant difference in the 90-day complications. So in the first 3 months, there wasn't any difference in terms of complication rates. So this is a paper which gives us a projection. So the question that was asked, can robotic revision rates make robotic total knee arthroplasty cost neutral with manual total knee arthroplasty at a 10-year follow-up? So this is a projection. So the same team that did the previous study, they looked at it. They looked at the National Joint Registry cumulative revision rates for the implants was 3.37 at 10 years. So if you do, this was the triathlon prosthesis. So the projection that about 3% of all these cases will need revision in 10 years. So if we calculate this, we calculate for the 2,392, 81 revisions will have to be made in 10 years. The only thing that was confirming that the price is high, this is the main point, 272 revisions would need to be prevented to offset the greater cost of robotics. So just to explain this clearly, so let's say for this to be cost effective, especially in terms of revision rates, we're talking about if the rate was more than 300%, then 300 cases, then it would be cost effective. So the data suggests that it's not possible for robotic arthroplasty to achieve cost parity with the mechanical manual methods. So the cost is just too high. I will not go into the figures, but there is a difference. So the last thing that I wanted to show you was there was a paper saying that looking at the cost effectiveness and how robotic can save money in 1 year. Here they matched 1 to 5 cases from robotic to mechanical manual method. So 4,452 patients were compared. The robotic had higher discharge rates to home. They had less home health utilization. They had lower need of episode of healthcare. So a nurse coming to their home, extra help, it was better. But looking at all of this, the price is still higher with the robotic, so it's still much more expensive. And there was not any significant difference in terms of complication rates looking at 1 year. So this is another paper. Just as you know, I'm not an expert in economics and numbers and figures, but this is the numbers that I found. This is another paper from Australia where they looked at a comparative cost analysis of this surgery. We had 252, let's say 70% were primary mechanical, computer assisted and robotic, 30% were robot assisted. They analyzed all the figures in terms of hospital stay, staff utilization, going to the emergency department, x-rays to be done, medication. They looked at everything. They found that computer navigated had a shorter surgical time. The robotic assisted had faster discharge rates. And the total in-hospital cost, there was no significant difference in terms of computer-assisted, navigated. So they're about the same. The in-hospital cost, it was significantly more expensive. So the robot-assisted, it cost the hospital per 21,000 per patient, while looking at the navigated, it was about 19,659. So what's the conclusion that we can get here? And I know this can be debated. It is not cost effective. Currently, looking at our data today, this is what I found out. It is not cost effective. But we are doctors. We're not. Our main goal is to provide better care to the patient. The most important question, I believe, is not is it cost effective. The most important question is robotic surgery or robotic arthroplasty better than conventional methods? I think this is the question that needs to be asked and answered. I do not believe right now we have all the figures stating that it is better, but I believe in the future it might be better. There is many factors. I looked at many papers saying that the volume, depending on the volume of cases, it might reach a parity. Currently, we don't have these figures yet. The aim of robotic surgery is not just things that we have in mind or fancy devices. No, I think it's thriving for excellence. Still now in robotic, especially talking about knee arthroplasty, the figures are not that great. We have a large number of patients are not happy with their total knees. So this might give us a step forward. Is this surgery the future? I believe it is the future. Currently, as I said in the introduction, we guide the robots. In the future, it will be artificial intelligence. The robot will guide us. There will be a large algorithm of many different patients, a huge number of patients, and the robot will tell us, do a 3-degree cut, give us 2-degree varus. This with artificial intelligence, I think the robot will guide us. I think this will be in the very near future. The last question, will be replaced by robots? Inshallah, inshallah, not in our lifetime. Thank you, everybody.
Thank you, Dr. Mansour. Do you think that we start questions now or at the end of the session?
No. لازم نمشي.
You don't wait to be questions?
لا بالفلوس خذ راحتك بس يعني ask me anything you want. If anybody has any question, I'm more than happy to answer. Let's
start from the audience. Do you have any questions for Dr. Mansour?
It's not a question, it's just a thought. I think the more we depend on the robot in the future, the new surgeon will purely depend on the robot to guide them. The new fellowship maybe will be like robotic fellowships, and that I think is dangerous in case if we need to troubleshoot like an autopilot. If the autopilot is not working, the pilot should know how to drive the airplane. I think it should be fundamental that you know how to do it without robot. Then it's an extra step for the master surgeon, not for the beginner to start with the robotic? What's your thought about this?
My thought, honestly, all my career, let's say, all my training I used to do computer assisted. So before starting computer assisted, definitely I was trained to do the mechanical manual methods, then going to the computer assisted. The problem is, I think in the near future, it will be the norm to do robotic. It will be the standard. I do ACL surgeries, many ACL surgeries. Before 20, 30 years, the conventional method was to do an open ACL reconstruction. Currently, we do arthroscopic. If you ask me to go to open technique, I honestly do not know how to do it, because the norm is to do arthroscopic. And I think in the future, most of our fellowship will be trained only to do robotic surgery, because this will be the standard care. I agree with you that it is currently what you're saying. This is not for everybody. You have to be trained well, knowing how to use this technology. But in the future, I honestly believe, I think it will be the norm.
Dr. Ali, also I want to add something that once robotics started as a fully active systems, and these fully active systems have shown a lot of complications, and that's why the robotics now are shifting to semi-active or active assist systems. And I think by the experience for both patients and surgeons, now we all know that surgeons should guide the robots, and I think it's a bit of fantasy that the robots might guide the surgeon, because it has been started already as a fully active, and it has shown a lot of complications. So in a matter of complications, in a matter of responsibility, I think it will continue like this. Surgeon should continue leading the robot, not the robot will lead the surgeon. I just want to add something for
just before you add, this what you're saying is very interesting, because I had a dinner with one of the pioneers in this technology. These guys believe that in the future, AI will take over, and we will not lead the robot will lead us. This is the guys doing this technology. You know, I didn't, when I was hearing this, I got sad. But this is what the pioneers have to say about this. They believe that in the future there will be algorithms, and artificial intelligence will tell us where to do the cuts and where to do everything, the sizes of the prostheses, everything.
I agree with you. One more thing, that most of the paper published to compare robotics to conventional TKR, actually they published this results according to the alignment philosophy, the old alignment philosophy. It's a mechanical alignment. And the problem with the mechanical alignment, as you all know, that we have at least 1/5 of the patients are not happy for no reasons, because they have changed their pre-arthritic alignment. And I think the benefit of robotics is not to target the wrong target, is to aim for the right target and not to change the patient anatomy. And I think to have a precision tool like computer-assisted robotics or navigation, it will help you resurfacing the knee joint, and aiming to decrease this number of unhappy patients. At least 20% of these cases are unhappy because of this. That's why the results of comparing conventional to robotics, actually they're not real results, because they didn't change their mechanical philosophy, and they kept doing the same one size fits all. However, they used the robots to execute their old-fashioned plan.
اتفق معك 100%. I agree with you 100%.
Thank you.
أنا عندي one point.
صباح الورد.
So it's not a question, just a note. Many of the studies you mentioned here, it's not like critical appraisal. It's just a note that the cost, as you said, in most studies cover that robotic costs more. So wouldn't that give the studies a bit of bias, as most of the higher socioeconomic patients will always go for the higher cost surgeries and the fancier surgeries, and we know by many literature that the people with higher income will do better in surgery.
I understand your question, but even though what you're saying is right, like I believe what you're saying is right, the problem with the robot is the price of the device itself. The price of the device, if you keep it in mind, it is much more expensive And the price gap, even if you compare with other kinds of methods, I think the price of this technology will definitely go down with time. When we started doing computer-assisted navigated total knees, the price was much higher. Now, looking at this technology, the price is cheap. Many patients, as you said, wanted this fancier method to be done. And I worked in a department for 3 years. I only did computer-assisted. Patients came for this technology, wanting this computer-assisted. عمليات بالروبوت, عمليات بالcomputer. They wanted this technology. But the price gap comparing with the conventional robotic and the mechanical, the robotic price of the robot itself is much higher.
So within that, give those patients higher support, and that eventually will give them better outcome from shorter stay and stuff like that.
Maybe maybe there is some bias. I cannot tell you if there was or not. Wallah, ما أدري.
Badr, thank you for the question or the statement. It's absolutely brilliant. So the reality of the matter is patients who have better access to healthcare will do better, whether it's conventional or robotic. If they have the means, they will definitely go to robotic surgery, and they should do better. Dr. Majid is right, and Dr. Mansour is right. Now, all the technology is focused on where we put our implant, not the design of the implant. So robotics is going to help us do that. So the functional alignment, which is coming into place now, is the way forward. So like Mansour said, robotics are here to stay. And I think in a country like Kuwait, where expectations are extremely high, it is the way forward.
Thank you.
Dr. Mansour, thank you very much.
يعطيكم العافية. Thank you.
Okay, we had a slight change in the schedule. Next is going to be Dr. Muthanna Sartawi. Dr. Muthanna is quite known. He's a pioneer in the same-day surgery, both internationally and regionally. So it's going to be a Zoom meeting.
Hello, good morning. Can you hear me?
Good morning, Muthanna.
Hi, how are you? Is the audio clear?
We can see the lecture, but we can't see you yet.
No. Okay, but you can hear me? I just want to make sure before I get going, the audio is clear.
Yes, we can hear you.
Sorry. Is it good to go?
Yes, please, go ahead.
Okay, so thank you for inviting me to speak at this great conference today, and I appreciate you adjusting for me to present it via Zoom since I'm out of the country, since most of my practice is out of Kuwait. So today I will be talking about the role of custom-made implants in total knee replacement, and I heard the great discussion you guys had about one size fits all and restoring the patient natural kinematics. And if this is our goal, then this is the best technology, in my opinion, in today's world that will achieve these goals. So let's get through it. So my name is Dr. Sartawi, and I practice in hip and knee joint replacement surgery. So what's new in orthopedics? I mean, we heard a lot about the computer-assisted navigation, and this is what we did when I was a resident almost a decade ago, and it was the hot topic. And all of this, as you guys mentioned, was to get the perfectly balanced knee. Then things have improved into handheld navigations, and then robotic surgery, which we've heard about. These giant companies started making these robots, all in order to achieve that goal of getting that perfectly balanced knee and restoring the patient's natural kinematics. What I'll be talking about is the custom 3D total knee. And this is an example of what it does, and we will see how this is achieved. So what is a custom 3D implant? It is basically manufacturing a knee from scratch to fit the patient's knee morphology and kinematics. And this is done by you doing a preoperative CT scan from hip to ankle to get the exact dimensions, sizes of the patient's knee anatomy, along with his axes and kinematics, in order to restore them as close as to perfect. There are different types of 3D technology. There's the custom, which is basically you manufacture a knee from scratch. scratch. And there's the matched implants, where you do the preoperative CT and then match it to the company's database of 85,000 CT scans and manufacture it as close as possible to the patient's normal anatomy. All this is using some 3D technology, along with the cutting blocks that are manufactured and sent to the surgeon via a box. Now, what are the advantages of this? Again, I mean, one of the most important concepts I want to focus on during this talk, and you'll hear me saying this repeatedly, is that our knees are asymmetric. They are not symmetric, meaning that we have different dimensions of our medial femoral condyles and our lateral condyles, whether they are an extension or an flexion. And the biggest issue is all the off-shelf implants today are symmetric. Whether you're doing robotics, navigation, or whatever else, I mean, you are shaping up the patient's anatomy to fit that off-the-shelf symmetric implant, which to me, I mean, does not make sense, because what we're doing here is we are shaping the implant to fit the patient's knee. So you get more accurate morphology anatomically. You can treat also a variety of pathologies. And the best thing about this, to me at least, is you're doing all the planning prior to surgery. You do not need all that big setup, all that huge robot, traffic, tracker pins, trays to start, while the patient's under anesthesia, trying to figure out, okay, I'm gonna cut it here, I'm gonna cut it there. There's minimal setup. All you get is this eye print of your blueprint plan of how you're gonna do this. The night before surgery, review it, and you walk in surgery and you execute. You just have a small box, a small tray, one scrub, and that's it. All the cutting blocks are disposable. You are not reusing any trays, so obviously, intuitively, that decreases infection risk. You don't have tracker pins, which we've had issues with, whether navigation or robotics, that can cause pin site infections or fractures as documented in literature. Now, obviously, there are downsides to 3D. It's a higher cost. But as I heard, I mean, a higher cost with a better knee, I think that offsets it. The track record, they've been out a decade plus now, as opposed to off-the-shelf implants who have reached almost 20, 30 years, if not more. The manufacturing time can turn off a lot of surgeons and patients because it takes a good 6 to 8 weeks to manufacture these. And if you're looking at the region here, it's more 8 to 10 weeks. I always recommend to have a revision system on backup if things go wrong, especially if you're starting this, it's in the early learning curve. And obviously have less options intraoperatively when it comes to constraint and stems. But the upshot is, if you're doing it right, you don't need any of that, because everything has been measured and all you need is what's in that box. Now, before I dive into the details of how 3D total knees are customized, we have to get some definitions, and we'll go through them. And these are some of the definitions. Some of them you've heard of: distal femoral condyle offset, posterior femoral condyle offset, gap balancing, calibrated and measured resecting technique, and kinematic and mechanical alignment. Now, as I mentioned at the beginning of the talk, our femurs are very asymmetric, meaning, as you can see here, and I hope my mouse cursor is here, this is the medial femoral condyle, and as you can see, it's bigger than the lateral, and it protrudes, it's sticking out more than the lateral femoral condyle and extension, and also in flexion. You can see the medial femoral condyle here is bigger and is protruding more than the lateral femoral condyle. And we'll see how this comes into play as we talk more. So what is the distal condylar offset that I will refer to in my talk? So it is the difference in distance between the lateral femoral condyle, where it sticks out, and the medial femoral condyle. We call this the distal condylar offset. Now, in flexion, obviously, this distal condylar offset is going to affect my extension. When we look at the flexion, the posterior condylar offset is the difference between the size of the medial femoral condyle and the lateral femoral condyle. Other definitions that you know by now is gap balancing, where we are relying on bony cuts and respecting the soft tissues in order to get that perfectly rectangular gap in both flexion and extension. And then measured resection technique, which is the traditional or conventional way of doing total knees, where we're basing our cuts on anatomical landmarks such as white sides, transeptal condylar access, mechanical access, and then altering soft tissues or releasing soft tissues in order to get a balanced knee. Now, the caliper resection is the basis of custom knees, and this is restoring kinematic alignment, but at the same time, we are looking exactly at the asymmetrical cuts that we're doing in the femur and tibia. And the only bone that's removed is the damaged bone, nothing more. Other definitions, mechanical alignment, here on the left is where we cut the tibia at neutral or 0 degrees, versus kinematic alignment or the Hungerford method where we leave the tibia at 3 degrees of varus or more, because most knees are in varus when we look at the standard population. So this is again looking at that distal femoral offset. As you can see, this is the measurement, the difference between them, and the posterior condyle offset, as you can see here, measuring between the medial and lateral posterior femoral condyle. So again, this is a great image that says it all. On the right, I mean, this is what off-the-shelf implants are. Everything is symmetric. And this is a problem because guess what? I mean, our knees are not symmetric. They're very asymmetric, as we saw from these units or these definitions I was talking. And this is what a custom knee looks like. It's asymmetric to match the natural anatomy of the knee. Now, when we look at these offsets that I just discussed, the distal condyle offset and the posterior femoral offset, they can vary quite a bit. I mean, the mean is, for the distal condyle offset, is almost 1.6 millimeters, but in some population, it can go up to 5 millimeters, and we'll see how that plays a role when we're balancing the knee. Same thing with the posterior condyle offset. The mean is around 3 millimeters, and it can go up to 7, and that can affect the rotation, especially if we're doing robotics or conventional knees. I mean, you have to really internally rotate some of these components in order to achieve that kinematic alignment. Now, what about the joint line? Let's look at the population. This is a great paper that came out of Australia looking at the alignment of patients. The boxes on the left are the non-arthritic. I mean, and neutral mechanical alignment in the standard population is only 24%. Most patients are 75% in varus. So the question is, why are we cutting them in neutral mechanical alignment when everybody is 75% varus? I mean, you'll get answers from traditional surgeons that if you put the tibia in varus, it will fail. Now that's been challenged, obviously. When we look at the ligament tension, as we know, the knee on the medial side in flexion extension is tighter. And when we measure this was a study that was done to measure the tension. It's 2.1 millimeter medially and 7 millimeters laterally. So when we're doing a conventional total knee, we always want that snug medial joint tension as opposed to accepting a bit of lateral play. So when we did the calibrated measured resection technique, let's see how we restore the tension, because the tension itself plays also a big role in the natural feel of the knee. So this is a very important graph here, and I want you to focus on this. If we measure the normal knee tension on the medial side, it's around 15. On the lateral side, which is green, it's around 6, which means that it's looser or more lax on the lateral side. When we do a measured resection total knee, look at how we're shooting up that tension on the ligaments on the medial side. It's significant, exponentially significant. And then if we look at the gap balancing, it's a bit more forgiving. However, we are still quadrupling the tension of the ligaments. Obviously, that has its effects on the patient's kinematics, pain, and whatnot. Now, the calipered resection technique, which is here, is the custom made total implants. This is how they are balanced. You are seeing that the tension on the medial side is very close to the natural tension, ligament tension of the knee. What about femoral rotation? The goal of our total knees is always to have that perfectly centralized patellar tracking, and to get this, you want the trochlear axis to be parallel to the transepicondylar axis. Now, this is a kinematically aligned knee. If you're doing robotics or navigation, sometimes if you're going to leave the tibia in that varus to restore the patient's constitutional varus, you tend to internally rotate the femur in order to open up that lateral space and close the medial flexion. And studies have shown that with patients who have a higher posterior condylar offset difference, if you're doing kinematic alignment using navigation, you can really interrotate them and have patellofemoral tracking issues. Now, when it comes to the conventional way, I mean, you have less tracking problems because you tend to external rotate. But however, you're not getting that perfect parallel trochlear access to the transepicondral access. Now, this is what we do in 3D custom knees because we are measuring the offset. It's asymmetric, and everything is done through the patient's anatomy. We get very nicely parallel trochlear access to the transepicondral access in order to achieve that perfect or close to perfect tracking. So as you can see, the asymmetric nature of obviously the normal knees or the natural knees, which is reproduced or restored in custom knee technology, helps you with balancing, making it closer to what we all tend to achieve or strive to achieve the patient's natural kinematics. It reduces ligamentous laxity, patellar tracking issues, and we restore the alignment of the patient. This is an example of a custom total knee where it's identity imprint. It's a software that it's used. It is CT based, as I mentioned. They have the software that analyzes the bone using 3D technology, and you have two options. There's the custom identity where, as I mentioned, the knee is manufactured from scratch to match precisely the patient's knee. Obviously, this is more expensive and has a longer lead time. And then there's the best match imprint. And this came out in 2021. The whole idea of this best match imprint is to expedite manufacturing of the knee. So in the best match imprint, you are not getting 100% custom. They are basing it on their 85,000 CT scans of the knees and seeing the closest match to the patient's knee and manufacturing that knee. That reduces cost. There's a faster turnaround. And you are still much better than off-the-shelf implants because you're still getting that asymmetry very close to the patient's anatomy, yet obviously not as accurate as the custom 3D total knee. And obviously this allows competitive pricing, and the surgeon can select based on obviously the patient's wishes. So the idea of 3D, again, I'm saying this over and over, which I think is the key point or the buzzword in this, is we are respecting the femoral asymmetry of the normal knee in patients when we're doing this by measuring these distal condylar offsets and posterior condylar offsets. And these are the only implants that do that. This is an example of a custom knee. As you can see, I mean, it's very cool that you have the lateral polyethylene is a bit thicker than the medial, which I think all of us see that when you're doing total knee. You're always a bit tight medially, lax laterally, and sometimes you have to do a MCL release in order to fit that poly in to catch up with the lateral side. Well, with custom implants, you don't have to do that because they take that into consideration when they're doing the pre-op planning and manufacture the knee. This is what it looks like, the imprint you get before surgery. I mean, you don't need a huge robot and tracker pins and, 3 people standing and telling you the trackers are working or not working. All you need is this 2-sheet blueprint that you review the night before surgery, and you stick it on the wall while you do surgery, and you just make sure that you are going on track. So what are the outcomes of customized total knees? Obviously, there hasn't been huge studies on this, but we've looked at satisfaction. This is a study from 2018. It showed that 90% of patients were satisfied over a 2-year period. And the interesting thing about this study was that patients with bilateral implants, they had a conventional knee on one side and a custom knee on the other side. And they reported 88% reported that the natural perception of the knee, they felt was more with the custom knee. Again, these are other studies that shows that high satisfaction rates of the knee, and this is registry data for survivorship. When I looked this up as I was doing the study, this is from the UK, it shows that there was a revision rate of 0.5% at 4 years, which is very good versus the 1.9% for all TKRs. Outcomes, it has been shown that with compared to off-the-shelf implant, there's estimated less blood loss once you get used to it, less tourniquet time, Length of stay is better because supposedly when you're balancing it, you're doing lesser cuts, you're doing lesser releases, and you're having less pain and better range of motion. So in conclusion, what are we achieving here? We are restoring the natural femoral asymmetry. We are restoring the patient's constitutional kinematic alignment. And as you guys mentioned, one size does not fit all. I mean, with the other technologies, we are, yes, trying to reproduce the patient's kinematic, but we are shaping the patient's bone to fit the off-the-shelf implant. With custom knees, we are shaping the implant to fit the patient's anatomy. Thank you.
Thank you so much, Dr. Musanna. Actually, this lecture added one more step in front for the knee arthroplasty surgery, because we used to.
Sorry to interrupt. This is just the patient less than 24 hours after this custom knee. He did the conventional knee on the other side, and he's showing off.
This is the one you did yesterday about noon.
I mean, again, it just shows that they do great. Okay, sorry, Dr. Shaheen. I interrupted. Go ahead.
No problem. Actually, we used to have our hip patients happier than our knee patients, and we kept asking why we have 20% unhappy patients in the literature for the knee replacement surgeries. And I think now we were on the right track by starting by changing the alignment philosophy, using the technology, and also customizing the implants for the knee replacement surgery. It's a really important and interesting lecture. Thank you so much. Do you have any questions? Okay, thank you.
Thank you, Dr. Musanna.
Thank you.
Next is going to be Dr. Majid Shaheen. He is going to share his experience, how he started using ERAS in Farwaniya Hospital. Take it, Dr. Majid.
Thank you. Good morning, everybody. I have nothing to disclose. Here are my two mentors in Canada, Dr. Pascal André Vanditoli and Dr. Martin Laveni. Dr. Pascal André Vanditoli, he's the lead of enhanced recovery after surgery in Canada. He's the one who started adopting ERAS in arthroplasty, ERAS protocol in arthroplasty in Canada and University of Montreal. And now he's the lead of this protocol in Canada. So why do we need enhanced recovery after surgery to improve our preoperative care provided to our joint replacement patients? Actually, most of the studies have shown that applying and adherence to enhanced recovery after surgery protocols have improved patient postoperative care and decreased complication, reduced length of hospital stay, and also increased early return to function. So what's ERAS protocol? It's an evidence-based multidisciplinary approach, supports better outcomes throughout the perioperative period for joint arthroplasty patients. So who's included? Patients, anesthesiologists, surgeons, physicians, and also physiotherapists and our nurses. Reviewing the literature, actually, we have to tackle our goal. To tackle our goal, we have to find the problems. So the potential problems that might face our patients and that might hinder the success are pain, nausea and vomiting, orthostatic hypotension, neural retention, hematoma, wound discharge, loss of motor function, anemia, DVT, and infection. Actually, 40% of these complications are anesthesia-related. Each of these problems might happen to any patients, and actually, we don't know which patient. We cannot predict which patient will have this complication. So our goal throughout the continuum of care is to increase patient satisfaction and engagement, decrease pain while minimizing opioid use, avoid patient sedation, improve patient early return function mobilization, decrease postoperative anemia, and decrease wound complication, decrease DVT risk, and decrease length of hospital stay, and increase patient satisfaction. Other benefits for the institutions, increased efficiency and decreased frequent complications, increased bed availability, decreased postoperative outpatient care, and decreased costs and resource exhaustion. Our target population are all adult patients requiring joint arthroplasty. Actually, in my opinion, that any patient should be considered for ERAS protocol regardless of the planned hospital stay. So the inclusion criteria are all arthroplasty patients from 18 to 80 years, patient understanding the program requirements, and patient ability to give informed consent. Our exclusion criteria are physical limitations and handicapping, cognitive or communication problems, need of long-term urinary catheterization, coagulation disorders, and long-term anticoagulant use, systemic disorders such as patients who need cardiac monitoring, ICU admission, or dialysis. So complications can be avoided by patient selection and preparation, education, preemptive medications, anesthesia, which is the most important part of this protocol, surgical technique, and postoperative care. So ERAS clinical pathway and shifting of the surgical care paradigm has 6 phases. The first phase is a patient and family engagement during our consultation, our first consultation, the OPD. And the second phase is patient optimization before admission. And then comes the preoperative preparation and intraoperative optimization, postoperative optimization, and after discharge. So let's start with the family engagement and patient and family engagement. We have to avoid only verbal information exclusively. We have to give our patients photos, videos, flyers before, during, and after surgery. Patient should know his pathway, starting from the first visit in the clinic till he will return to his normal function. This actually, it's a journey for the patient, and he should know exactly what's going on and what he is expecting from our care. It has been found that engagement of the patient in his decision and his journey through the surgery will improve return to function and decrease the complications. So again, patient should have such a flyer in his hand to know all the process and steps that he might go through, starting from the first visit till he will return to normal function, maybe after 3 months or more. So that starts with the pre-admission optimization. Pre-admission optimization is the responsibility of our fellow colleagues, anesthesiologists, and physicians. So they should follow an evidence-based approach of preoperative assessment and optimization of patients. Some risk factors are optimized, can be optimized, like anemia or like uncontrolled diabetes, UTI, or venous insufficiency. However, we have unmodifiable conditions like renal insufficiency, for example, and these patients should be excluded from the protocol. Then comes the role of nutritionist. Preoperatively, we have to refer our patient to a dietitian if we thought that he needs this. And postoperatively, patient should return as early as possible to the normal diet. Preoperative optimization, once the patient is admitted to the hospital, we start with fasting and fluid management. We should learn our ward nursing team to avoid long-term fasting. So patient should only fast for solids for 6 hours only, and for fluids, clear fluids, or he can continue taking clear fluids for 2 hours before the surgery, and especially the carbohydrate-rich diets. Our patients actually are for age group that's very critical, and we shouldn't reach the process of dehydration and catabolic status before going to the surgery. Post-operatively, patient, if according to the anesthesia, and I will come to this later, patient can resume his normal diet and drinking as early as possible, and unlike before that, we have to keep the patient for 4 hours, 6 hours fasting post-operatively. So then comes the role of primitive multimodal analgesia. Actually, this is our role ortho team. Patients are given a cocktail of analgesias that might tackle the pain differently by many ways. And it should be started primitively, should be started before the surgery, so we can block the pain receptors preoperatively and prevent hyperalgesia, pain, and decrease the pain intensity and total analgesic requirement. So the primitive multimodal analgesia, patients are given 1 to 2 hours preoperatively by the ward nursing team, paracetamol, Celebrex, and Lyrica, and Tramal. All these medications will have a synergistic effect to avoid long-acting opioid use. Then intraoperative optimization. We will ask our anesthetist to give our patients a pre-incision medications, and our anesthetist will collaborate with us to give the patients a multimodal anesthesia, and then our role for the best surgical practice. So what's the pre-incision medications? We're giving our patients, definitely, as we said before in the word, multimodal analgesia, and then antiemetics, anti-inflammatory, and prevention of anemia like tranexamic acid and antibiotics. So there's antiemetics like Zofran, for example. And then anti-inflammatory dexamethasone. It has been found that giving patients dexamethasone preoperatively, it will decrease the inflammatory process immediately post-operative, which decreases also the pain post-operatively. And it also, dexamethasone has another effect of decreasing nausea and vomiting post-operatively. Prevention of severe by giving the patient tranexamic acid and regular preoperative antibiotics. So the role of the multimodal anesthesia is the technique should aim to reduce post-operative pain, avoid patient sedation, and minimize the risk of orthostatic hypotension or urinary retention, and limited prolonged motor function loss after surgery, so the patient can start moving as early as possible post-operatively. And here, the role of our anesthetist. Actually, giving the patient multimodal anesthesia and avoiding by all kinds the use of opioid, either generally or intrathecally. So the patient, if the surgery is short surgery, like one side total knee replacement or one hip replacement, so patients are given spinal anesthesia that contains only local anesthetic like chloroprocaine or bupivacaine, together with sedation with the high dose of propofol, and we're injecting our patient periarticular infiltration. If it's a lengthy surgery, we opted for epidural anesthesia and sedation and periarticular infiltration also. And the epidural anesthesia shouldn't contain adjuvants and shouldn't contain opioids. So this will affect, the effect of this, there is no motor block, opioid-free, no benzodiazepines, and minimize the orthostatic hypotension post-operative that might prevent our patients from starting mobilization as early as possible. So it has been found that intrathecal opioids like fentanyl, it has significantly prolonged the sensory and motor block, and it has a systemic absorption also, so it might lead to nausea and vomiting, urinary retention, pruritus, and respiratory depression post-operatively. So just try to negotiate with your anesthetist to avoid fentanyl. They like fentanyl because it to prolong the anesthetic effect. However, just try to convince him not to use fentanyl in the intrathecal anesthesia. So here it comes the role of multimodal anesthesia. It's our role. It's prepared by the anesthesiologist and the nursing team. So we have two periarticular infiltration. We're preparing two solutions, solution A and solution B. Solution A, it contains local anesthetic and ketorolac, anti-inflammatory, and epinephrine to decrease bleeding post-operatively and to cause hemostasis. And the solution B, because it's infected superficially, it contains only a local anesthetic. So this is our rule now, the best surgical practice. Just try to avoid tourniquet and preventing surgical site infection by routinely antiseptic solutions, tranexamic acid to reduce blood loss, surgical approach. Actually, try it depends on the surgical preference. However, you have to minimize soft tissue dissection and minimize surgical time and proper hemostasis. Then comes the wound closure. Wound closure is a very important part of the process because the patient sees only the wound. Actually, the patient doesn't know what is inside his knee. However, he only sees his wound. So we should aim to prevent wound discharge and minimize dressing changes and minimize nursing care. Actually, patients who will get out of the surgery with a bulky dressing like that, I doubt he will be able to walk or start mobilization post-operatively. So patient should have a light dressing that is dry, and he will, psychologically, he will know that it's not a major surgery, so I can start moving as early as possible. And there is no bleeding also. So we used to do this by a watertight closure of the capsule and a watertight closure of the skin, and also we're using a Dermabond, which is a surgical glue, to prevent post-operative discharge. Also, part of the hemostasis post-operatively, I'm keeping my patients with a knee flex at 60 degrees for 4 hours to allow a tamponade effect for post-operatively and to control the bleeding post-operatively and decrease the hematoma inside the knee. We have to teach our recovery nursing team what is that visual analysis score and how to calculate it. So once they know how to use it, they will know what to give to the patient. If the patient is having pain less than from 3 to 6 over 10, they can give him paracetamol. If pain continues or it didn't control, it increases, they can add tramadol. And if pain continues and increases up to 6 or more, they can add oxycodone. Pain more than 7, they can add another step, which is hydromorphone, which really try to just give it as orally to avoid complication of the opioids. So here is the role of physiotherapist. So patients should start mobility and activity as early as possible. No range of motion restrictions. First mobilization should be the night of the surgery. And should be done actually by the surgeon, because the patient will give you will feel confident once you're beside him after the surgery. Most of us will do the surgery and leave the patient in the hospital, and patient will think about, okay, I have to ask my surgeon before doing anything. The physiotherapist haven't seen me during the surgery, and so patient will wait till he will see you next day or maybe the day after to start moving. So you have to be beside the patient immediately post-operatively to give him the confidence to start walking and to tell him that everything is okay and you can start working, and I'm with you here to start working. And actually you have to give the patient not only instructions, you have to give him flyers. So he will have these flyers all the time in his hand in the hospital, so he can, if he have any questions, these flyers should contain frequently asked questions, should contain photos. And the patient might have, for example, ecchymosis post-operative or edema. So if the patient have a flyer in his hand and this flyer contains photos that have edema, patient with edema or ecchymosis, they will understand, well, this is a normal process post-operatively and it's not a complication, so he can start moving. Also, if it's possible, physiotherapy conducted at home visits or in outpatient clinics. So we have to teach our nursing team. We have to teach them to check the vital signs every 30 minutes twice, and then every hour twice, and then every 4 hours the rest of the day, and then TDS. You don't want unexpected complications like to be discovered the second day. And they should also learn how to use a cryotherapy or game ready. Closing the wound in a watertight fashion will prevent them from the annoying daily dressing or dressing management. Patient, if his urination is spontaneous, he should start going to urinate without, and you should remove the Foley's catheter immediately post-operative, and they shouldn't keep the Foley's catheter post-operatively. One thing is to allow him to move around, and the other thing is to avoid the post-operative UTI and the expected complication after this. So, Day 1 post-operative, our ortho team should look at the hemoglobin and check it if it's above 85 or not. And we should check our thromboprophylaxis according to the protocol. And we should check that the patient is taking a regular analgesia, and which is an opioid-free analgesia. And this patient should be given anticonstipation as regularly.
Time, sir.
Yeah, already there. So finally, our experience in Farania Hospital, I've operated during the last year about 140 patients, so the joint replacement, 82 TKR and 15 unilateral patients, and 36 bipolar arthroplasty, 2 aseptic revision, and 2 stage revision, and 1 THA revision. The complications that we faced, actually it's 11 patients. delayed early mobilization, 4 patients, one of them because of uncontrolled pain. And actually this patient, it was a bilateral simultaneous THR, and I couldn't, my anesthesiologist was not there, and I have been faced with another anesthesiologist who was against the idea, and he insisted to give the patient a general anesthesia and PCA, and actually he refused also to give the patient an epinephrine inside the local infiltration, and finally the patient her pain was not controlled post-operatively, and she was not able to walk until 3 days post-operatively. Also, we have 2 patients with orthostatic hypotension because of fentanyl in the spinal anesthesia. Also, this happened from another fellow anesthetist who was new in the hospital, and he was not following the protocol. And also, we have 3 patients with urine retention. 2 of them was those who took fentanyl. And finally, 2 patients with heavily soaked dressing because of bleeding post-operatively because of inappropriate or non-watertight wound closure. So for successful implementation, what we need? Local champions for each discipline: ortho, anesthesiologist, nursing, physio. And preset orders, we have to give our patients flyers or give them videos, and we have to adhere to our ERAS protocol without changing anything to achieve success. Also, active engagement of patients, family, and all caregivers. Patient family education by printed booklets, videos, counseling, and continuous education of all our healthcare providers involved in the clinical pathway of the patients through presentations, webinars, and training. So this is an example of the preset orders that I've made in Faraonea Hospital. At the right side, you can see patients, he will have these pictures in his hand. So once he will have ecchymosis, he will understand that it's a normal process post-operatively and nothing to worry about. This is a team for us in Faraonea Hospital. It's the best team. Thank you so much.
Thank you, Majid. That was excellent. Do you have any questions from the floor? Please.
There's no question, just a comment that couple of things which we have modified has helped, and it might help you. One is we avoid giving ketorolac because some patients do get kidney problems. So our elderly patients are also going home very early because we stop giving ketorolac completely. We only give adrenaline and local. So that one of the things we have changed in the last 3-4 years.
What was the complication of ketorolac?
The kidney hit. So
okay, usually this is to be defined preoperatively by the anesthesiologist. If the patient might have a renal impairment, we have to avoid all kind of non-steroidal anti-inflammatories, including ketorolac or even Celebrex, for example, post-operatively.
So I mean, ketorolac actually, even in the middle-aged patients, sometimes even the normal kidney function can hit. So that's the issue. So now
from local absorption.
Yeah. Sorry.
From local absorption.
Yeah. Well, the systemic absorption.
No, actually, we're not giving ketorolac as a systemic. Systemic route. It's local infiltration. Yeah.
I know we're giving local, but it still can hit the kidney. Secondly, giving tranexamic acid inside the knee, then it will prevent your soaking of the dressing.
Yeah, actually, usually our patients are taking 2 milligrams of tranexamic acid, 2 grams of tranexamic acid preoperatively, and if it was a lengthy surgery, I will ask my anesthetist to give them another 2 grams, or I will inject them with tranexamic acid locally. Thank you.
Thank you, Dr. Majid.
Thank you so much.
I have one more question, if I may. Thank you so much for amazing lecture. My name is Hana Amalid, physiotherapist in Fawzia Sultan here.
Okay.
I wanted to ask, because you talked about the pre-admission optimization, and we now know a lot from research that prehab is also an important part of that. And with a lot of other procedures, we more or less normalized it with ACLs, and these surgeries, even the TKRs and THRs, are usually planned for months ahead. Yet, I've been in Middle East for almost 9 years, and I haven't seen a single patient that would have had prehab before the surgery.
Totally
so
agree.
I wanted to ask, your opinion on that.
Sure, definitely. I totally agree with you. We used to do this in Canada. We used to send our patients for a prehab. However, once I've arrived here, I found that the physiotherapists are overloaded, really overloaded. They're very, very lower number compared to the procedures I've done daily, and actually I'm a bit shy to send them patients that didn't have yet an operation to start the physiotherapy. However, I wish I had this option.
Thank you.
Okay. Gentlemen, Dr. Muthanna has a question on the screen.
Go ahead, Dr. Muthanna.
Farwania Hospital. I just have a few questions. I mean, obviously, we all are for rapid recovery. I didn't understand just why NSAIDs you recommend, or you recommend against the use of NSAIDs. My other two questions are drains. What do you think of drains? I mean, because I know a lot of the studies are against using drains in total knees. However, they have been shown to decrease pain and less chances of hematoma. And my last question is, and sorry for these three questions, is how are you doing the home care with Farwania? Is that being done through the hospital, or are you outsourcing a company for patients and they have to pay extra?
Okay, thank you, Dr. Muthanna. I am not sure that I've heard the first question. However, I will answer you for the second question first. The second question was about the drain. Actually, I'm not using drain in my patients unless revision cases. And actually, a good hemostasis, which starts from the good surgical technique and the tranexamic acid and putting the knee inflection for 4 hours post-operatively and using a game ready post-operatively also. All this, I think, has properly controlled the expected post-operative hematoma, and most of my patients actually have never had a complication regarding the hematoma or intra-articular collection post-operatively. And I know that it's a big debate in the literature using or not the drain. However, I found myself that using drain will prevent the patient from early mobilization. Usually patients actually, it only knows about his surgery what he sees. So he sees that he has a big surgery and there is a blood coming out from his knee, and this might hinder them from starting mobilization as early as possible. So I think that it's important for not to put drain, in my opinion, and I haven't had any complications regarding the post-operative hematomas. And actually, the third question was about how we did this in Farwania Hospital. Actually, I've started this after having a talk with the head of the anesthesia department, and actually, Dr. Shamsah, he's very interested in supporting the idea, and he's in his way to apply an enhanced recovery after surgery for all the surgical specialty in the hospital. It took me a bit to convince other parties. Actually, as mentioned, the success of implementation, it needs that you have to search for the believers. You have to find a believer in each specialty. I know it's difficult. However, once you have them in your team, I think it's a great success. And what was the first question? Actually, I didn't hear it.
Well, yeah, I mean, I know you guys are in a hurry. Just like the NSAIDs, you said not to use NSAIDs. I wonder why you were against using anti-inflammatories in the post-op recovery period.
I think that question was aimed at you, Prof. How you're talking about ketorolac and how you don't use it. Yeah, so.
No, in our experience, we found that some patients get kidney problems. So that is the reason. So we were only injecting ketorolac in the knee. So we don't have problems using NSAIDs post-operatively. But because we inject high doses of ketorolac in the knee, and we found some patients having problems. Therefore, we stopped using it.
Thank you. Okay, we're going to move
Thank
on
you.
now. Dr. Nayan is next. He's going to be talking to us about managing bone defects. Thank you, Majid.
So away from the technology talk to the true manual labor of arthroplasty. So what do we do with those bone defects? I'll be concentrating on the acetabular side. So what causes those defects? The majority of cases is usually due to aseptic loosening, usually from those old plastics and old implants. Then comes the infections, the instability, wear and tear, and the others, such as fractures. Now, in order to know the defect, you need to classify it, and there are different classification systems. And usually, Poprowski classification is one of the true good classifications used in arthroplasty and orthopedics, which has some meaning to it, aside with the Vancouver classification. So Poprowski usually looked at the available rim within the acetabulum, the walls or the dome, the columns, and the medial wall, and then classified it accordingly based on those defects. Other classifications have challenged it, and other classifications came after with the use of further technology, 3D printing, and CT scan. And this proposed classification by Zag was by talking about the 3-point fixation of to the cup. So they looked at the 3 basic points where the cup can be held, which is the anterior superior aspect or the dome of the acetabulum, and then the ischium and the pubic rami. And based on that, they were able to customize the implant and help hold the whole defect in place. So 3 simple questions you need to ask yourself when you're faced with this. Is there any actual bone defect, and what's the magnitude of it? Is it mild, moderate, or severe? Is there any segmental loss within the acetabulum? Or is there any pelvic discontinuity where the whole pelvis is mobile? I mean, acetabulum. So mild, this can be either due probably infection or failure of ingrowth, and you have to revise it with simple or minimal bone loss. Moderate is where you can have some cavities, usually from aseptic loosening or from polyparticles. Severe is where you can see these types of defects and problems where you get scared. So any orthopedic surgeon, when they are faced with any of those cases, should do the following. 1, rule out infection, which is simple. 2 is to do some radiographs. And the radiographs we ask for is usually the regular AP and lateral. For most cases, to properly assess it, you do Judet views at 45 degrees. Sometimes you need a CT scan after the Judet views. And if you are questioning yourself if there are any pseudotumor or other pathologies, or to see the integrity of abductors, an MRI might help. So radiographs, everybody knows those lines. And what Poprowski says or have used is some of those lines to help identify the defect. So is there any superior migration of the hip center? This is where you have some superior defect down at dome. Is there any teardrop osteolysis? This is where the medial wall is in jeopardy. Whether or not you have available ischial bone, or is there any osteolysis? or any disruption of the ilioischial line or cohort line. So this is an example. And this is where Judet views actually help. So you have the obturator view, which shows the anterior column, and then the iliac view, which is here to show the posterior column. And sometimes you don't see the defect properly. This is where you ask for 60 degrees of Judet view to give you more imaging. So, acetabular revision. Is there a need for revision? Is the patient in pain? Is the implant is failing? You need to understand the defect and how to tackle it. At the end, the goal is to have a stable construct and to restore the hip center. And these are our treatment options: a jumbo cup, impaction grafting, which is popular in Europe, a cage, which is currently losing its popularity due to its high failure. However, there's some role in elderly, cup cage, augments, and later the custom tri-flange. So type 1 is just the regular revision, straightforward. You can use a regular primary cup with multiple screws. In this case, you just have an intact rim. The 2A is where you have some supremedial defect, and you have some good rim to have some stability to the cup. So this is a case with a history of breast cancer with METs, and unfortunately her cemented cup have failed. Just a straightforward revision with a slightly bigger cup, cementless with good screw purchase. And this is one of the good points of having a cemented cup. It's an easy revision if it's not infected. 2B is where you have a superlateral defect, around less than 3 centimeters of defect. You still have some rim. It's like less than 50% rim loss. Previously, they used autografts, such as the femoral head. However, one of the complications is non-union, and eventually that will lead to failure. Jumbo cups is one of the instruments I like to use. So jumbo cups is any cup that is big in size. So for the European and American patients, they have big balls. So you're talking about 66 millimeters in diameter in males, 62 in females. In the European population and the Asian population, it's a 64 for males and 64 females. Other studies have shown that you template the other side and go 10 millimeters above that. I think it should be a percentage and should be customized to each patient. The other option is to use augments. They can be used as roof or rims and buttress, and these are made out of trabecular metal, mainly tantalum, which are highly porous and allow ingrowth. So they help increase the bone contact, maximize bone ingrowth, and restore the rotation. And you can put them anywhere you would like. Type 2 is where you have a breach in the medial wall, and you can use augments to fill that gap. Now, the 3A, now we're talking about the big stuff. So this is what we call an up and out, which is superimmigration and lateral, superlateral migration with more than 3 centimeters of defect. The rim is not intact. This is where you need some cup cage and some augments to restore those defects and the alignment. So this is one of my mentor's case. So this was a failed cup with superlateral migration, and they used augments. And what you do there is you go in, you prepare where you want the cup, and then use the templates of both the cup and the augment. Once you're happy, You stick your augment and cement your cup into that augment, unitize it, fill it with screws, and then you cement the cup with the version you like. And this is the endpoint down there. This is one of Dr. Majdi's case. This guy is in his late 20s, if I'm not mistaken. He had a proximal femur replacement done in the past for a tumor, which got infected, and then was treated with a long spacer held with a bipolar. And throughout the past 5 years, he was on it. The bipolar had slowly migrated and caused this big defect here. We have been planning for this case to fix it, and these are one of the plans, or some of the plans we came up with. Either we use a jumbo cup with multiple screws to fill that gap, or we can use an augment with screws and use a regular cup, or we can use a cup with a high hip center. Unfortunately, these cases don't do well with the high hip center due to the great forces. So our initial plan was to go with the augment and the cup. 3B is the up and in. This is some major loss in the bone. This is where you use a custom tri-flange, a cup cage. This is where you have to make sure it's not a hip a pelvic discontinuity. So this is a case. This is an 80-year-old lady with a Thompson's prosthesis done in the 90s. She was doing well initially, and then with time, she noticed herself to get shorter and shorter and have more pain, to the point that she was very reliable on the walker to walk with. Unfortunately, she fell and had a periprosthetic fracture. This is, unfortunately, was on our on-call. So we did a CT scan, and the CT scan was one to evaluate the columns, and just because we know the collars of the Thompsons, I just want to make sure there is no bone between the collars to easen up the extraction of the cup. And I was right. There was some bone. Oh, you can see the. There's no laser. Anyways. You can see the bone here holding the head, between the head and the collar of the Thompson. This is where we use an osteotome to open up that. Another thing you can do is a CT angio to see if you're actually compressing on the vessels. As you can see on the CT, it is compressing the bladder rather than the vessels. So my initial plan was to do a proximal femur replacement and use the biggest cup available to hold that. Okay, press it out.
2 minutes, Trayan.
Sure. To hold everything together, and then just cement the dual mobility for stability. I also found a cage lying in the store. Unfortunately, the patient's acetabulum was smaller than the available sizes we've got, and we managed to put a regular cup with screws superiorly, and I left that patient non-weight bearing for 6 weeks to allow this ingrowth, and then touch weight bearing to allow her to mobilize. And this is 6 months down the line. She's able to walk, thankfully. She's a happy customer. Another case, this was a case I was involved in during fellowship. I'll go real quick. So this lady had a resurfacing done. She fell, and this happened. So intraoperatively, we checked the columns and found out that the posterior column was mobile. This is where the plate was applied and a big cup with multiple screws was inserted. We strictly told the patient to featherweight or toe touch. Unfortunately, a few weeks later, during my own call, this patient was walking and noticed herself to have some pain, and her leg became shorter, and this is what happened. And you can see on the J-Day views, the posterior column seems intact because of the plate. We're not that happy. And the anterior column, there could be a rim there holding it. And this is where a cup cage construct was done for that patient with multiple screws. Pelvic discontinuity, either in an acute setting, there's where your pelvic surgeon might help with some column fixation. If you have in a chronic setting, you need to bypass that discontinuity either by a cup cage construct or a custom tri-flange. So this is a patient with aseptic loosening and osteolysis, both in the proximal femur and on both the anterior and posterior columns. The patient started to have pain. Both columns are not supportive, and this is where a custom tri-flange was put in place. So basically, the company uses the 3D images where they can do a 3D print for the defect and the implant. They send it to the surgeon where he can check it, and then they send everything, and you do it step by step. And this helps bypass and substitute the defect. Thank you.
We only have time for a couple of questions. Are there any questions from the floor? Nayan, what's the biggest problem you're facing with the revision arthroplasty in Kuwait?
One,
we don't have problems here.
No, we don't have problems. We have two issues. One is we actually need a templating software to help usually know the sizes of the implants we need to use. Second is the scarcity of the implant and sizes.
Nayan, thank you very much.
Thank you.
Next, we have our esteemed guest speaker. It's Professor Sherman Sharma. He is a professor at Hello Medical University and School. He's also the head of the British Limb Reconstruction Society and the arm of that in SICOT. Welcome, Prof. Hopefully you'll have some time to play some tennis in Kuwait.
Go to the first.
Sorry?
Go to first.
Yeah, that's the first.
Oh, first is thank you?
Yeah.
Okay.
So, first of all, thank you so much for the organizing committee, Dr. Al-Mutairi and the whole organizing committee for inviting me and giving this opportunity to share some of my work. I have to say it's been brilliant, fantastic. I've heard all these talks and it's very good. So I'm going to do, I know we're running short of time, so I'm going to just try to be as concise as possible. So if you look at a problem, our problem is that we're doing a lot knee replacements. And they are very good, very successful. Some do go wrong. And same with ankle. And these are the numbers from the NJR in UK National Joint Registry. And the problem is not the normal knees, it's just the patients in the younger ages we're facing which are getting, if they get a problem, then we get really into a bit of a problem. So my name is Hemant Sharma. I work in Hull. I'm one of the limb-recon and bone infection surgeons, and we run the unit in Yorkshire for a number of years. And I also do arthroplasty. And I've been asked to talk to you guys about the role of circular frame as salvage in arthroplasty. What we're going to look at it is that look at some common problems, because the commonly is the knee and ankle, which is the main, so I'm going to just discuss those. Some challenges, the mistakes I have made in my practice, so I'm going to share with you, so hopefully you won't make them, and some things I've learned in time, and I'll share those as well. So let's look at this. An orthopedic nurse who used to work in our ward, young patient, had arthritis and had a knee replacement. Unfortunately got infection, had a two-stage revision, but was quite unstable, had a lot of problem, didn't want a revision. So we managed conservatively, and that's, I have to say, so it wasn't me, right? So managed conservatively, had a recurrent problems. She said she got fed up. She said, okay, can you do something? And they had done the revision. She was only 56, and by this time she had a post-op infection. And 4 years later, so she managed to get conservatively bits of things. And 4 years later, she said, I'm struggling, a lot of pain, infection not settling, suppressive antibiotics, nothing is working. So the idea was, what do we do? And the issue is that the only thing we can do is the fusion. So if you look at the arthroplasty, it is a distal femoral replacement. It's a part of the proximal tibia has been replaced. And if you look at the overall gap is about almost 10 centimeters there. If you have to fuse, you will lose that. You need that much bone. Plus also you need about 1 centimeter on each side to get a reasonable quality bone where you get good bony contact. So our problems with a young patient total knee replacement is that not only they're increasing, but if you look at the number of studies from New Zealand and one from UK, from Oxford, there's about up to 35% cumulative lifetime risk of revision for below 55. So young patient arthroplasty have significant problems, and most of them happen pretty early. And even at 65, they're twice at higher risk as compared to somebody over 70. So my take-home message about young patient arthritis is, think twice before you do a knee replacement. Salvage can be challenging. And is there anything else we can do to help these patients with the pain? And if we can do that, we should do that, delay the arthroplasty if possible. So if something goes wrong, our options are pretty limited. Amputation is not good, and culturally in some parts of the world is not accepted. In UK it's much more accepted, but people still hate it. And most of them will never walk again, because the energy consumption in the above knee amputation is significant. And then when it's come to you can't fuse it with a plate or a nail because of the number of issues with that, including the soft tissue problems. And other is the biomechanics. You have to put 2 plates to keep it a decent amount of stiffness, and which means there's not enough soft tissue to do that. So whenever I have a complex problem, this is how I work. I have a problem list, and the problems could be related to patient. So these are the patient problems. All those things were related to patients, and some of them I can tackle, so I try to tackle them. Then the patient problem related to the knee itself. And again, some of things I can tackle, some of things I can't tackle. Then the problem is related to me as a surgeon. Am I competent to do this operation? Is there I need any help? Do I need support services if I do a complex procedure? Who will help me post-operatively? And all this I put together and then see how best to deal with this patient. In all complex problems, this is my usual approach. So one of the biggest problems is the bone loss. So if you go back to our patient, we'll come back to in a minute. So this is, our problem is the bone loss. So you can do a shoe raise. The problem is, if it's anything more than 3-4 centimeters, it's very, very hard to tackle. And then what you really need is the shoe of this size. It's not working. Okay, it's not working. So a shoe of this size, which would be much more useful. Now, the other thing about bone loss is that you can do something, but you can also do a bit of lengthening with the circular frame. That's the advantage. But the thing is, these patients are elderly and lengthening is not that easy, so we need to try to keep that to minimum. And it becomes more difficult as they grow old. So in standard, where there's no DFR, no proximal tibial replacement, normally there's 5-6 centimeters. You can easily work with a bit of lengthening and a bit of combination of the shoe. The other issue we find is that a femur often have anterior bone loss, so you have a less bony contact when you're doing the fusion. In tibia, it's easy to put a opposing surface, a flat surface to easy. So when we have a problem, is the leg lengthening, as I mentioned, is the healing. And this is the case, if you go through from post-operative, it's only 2 centimeter lengthening. It took a long time to lengthen 2 centimeters. And if you look at any laser of literature, it says 2 months for a centimeter. It doesn't work in these people because they have comorbidities, they are not the best patients, they have all kinds of problems. And therefore, we need to be careful when we're lengthening these patients. So my take-home message for these patients would be, we need to have a custom plan for each patient. We need to look at it, that what this patient needs, and how best we can achieve with a combination of techniques. And try to keep the lengthening to minimum, right? And you will find that sometimes it's quite a long time. The other problem is the soft tissue. So with the soft tissue, there's a vascularity issue, and because of the skin is adherent, so can't really use it a lot. Then, usually gastrocnemius flap is fine, but if you're using a circular frame, what you can do is you can leave a space for plastics. And if you can do that, that works very well. And once that is done, you can complete the frame in the clinic or the ward, and you don't have to take patient back to theater. Let me give you another example of bone loss and the problems. So there's another ODP from a hospital at knee, washout, first revision, second revision. So if you are doing a surgery for fusion, my take-home message for you would be, if you're fusing the knee, the standard of care is a single-stage surgery. How we do it? You debride, sample, put some local antibiotics, change your instruments, want to change your gloves, maybe your gown, go back, same sitting, put on the frame, do the corticotomy all in one go. So this is the patient. Initial work was done under a sterile tunique. Clean it out, put lots of stimulant beads with vancomycin and gentamicin, align the frame to the mechanical axis, and complete the frame and do the corticotomy. And these are the post-op pictures with the stimulant beads, quite obvious. But the gap was too big. So we can shorten so much, but you can't shorten 10, 12 centimeters. So here we used a custom-made 3D printed absorbable graft cage. So in stage 2, we went in, opened it up again, cleared the stimulant, took some bone graft, some autograft, some femoral head, morselized like orthoplasty surgeons use, and then we put in a cage and put in and closed it. So this is looking, actually last week, her regenerate has healed, and the knees is a long gap, about 6.5 centimeters. It will take some time to heal. So my take-home message would be these: when the extensive leg lengthenings or the discrepancies, we should use combination of techniques to help. Yusuf did a lovely work. He published this paper in no time, actually. And one of the things we found was that, the slide hasn't changed, sorry. It's taking time. My next slide is not coming for some reason. Basically, it shows the paper which Dr. Marwan published, a systematic review of the knee fusion for the complex indications in the, what do you call that? In the salvage arthroplasty cases. I'm not sure why it's not coming, but next one is coming anyway. So this is, this is the work just about to finish and is going to publish. And the idea is that he looked at a lot of work on the external fixators for knee fusion, and a circular frame came out much better than any other external fixator. Then a few words about ankle replacement. And again, similar as knee, and soft tissue usually not a problem, it's the bone loss which is an issue, right? So what you do, this is an ankle replacement, and he had a failure, so they put the bulk graft. They put a bulk graft which really quickly failed, had a hindfoot nail. The problem with the bulk graft is they never completely incorporate, therefore they should be avoided. And so therefore, if you have to do bone graft, I would suggest do morselized grafting, which would be much easier. Unfortunately, the patient got infected, so if you remove the graft, put in a frame, do a proximal corticotomy, and lengthen it to reach where we want. So one option of leg length restoration is that, or sometimes you can do bone grafting. So this is a 77-year-old gentleman here. His ankle is failing. He has no symptoms apart from the varus. And then it's 2019, the COVID came, and we don't know what to do go in or not to go in, because he's totally asymptomatic. Finally, we decided it's probably time to go in, otherwise it will fracture things, make it worse. Opened it up, took it out, and here what we did, we impacted the morselized femoral head and autograft. And we put in a frame, and it healed quite nicely. So take-home message for this would be that leg lengthening is the most, with the frame, is the most consistent method of regaining your length. But in an elderly, you got to be careful. The problems is that if you put in a frame, it increases your frame time. When we looked at our results, we found that just for 3 centimeter lengthening, frame time increased for about 4 months. So what other option you can do is you can leave them slightly short and give them a shoe. That is another thing which would be quite helpful for them to have the day-to-day life and avoid a complex procedure. Other option is for how to preserve an ankle in a young joint. So it's a non-orthoplasty option, which is, so this is a 46-year-old lady, severe pain, can't function, can't walk, can't do anything. So just did a distraction of the ankle for 3 months. And so this is post-op 1 year, and you can see the joint space is reformed. This is a cartilage regeneration in the ankle. This is 3-year post-follow-up, again, no pain, no painkillers. Then 5-year, 8-year, and 10-year follow-up. He still has no pain. We have lost the regenerated cartilage, and if she wants, I'm happy to distract the ankle again. But she's 56. And now if she has to have a fusion, then the chance of subtalar problems or other arthroplasty, maybe, then the risk of failure is much less. This is a lateral view of similar case. Same patient, again, she's doing pretty well. She comes every year for a follow-up, for an X-ray. So my take-home message for young patient arthritis in ankle is that ankle replacement survival is, at the minute, not as good as hip and knee. And therefore, if you do revision, then it's even more a problem. So in young patient, distraction is an excellent option if you want to take that option. It can delay the arthroplasty and also the fusion, which it puts your subtalar and midfoot in the problem and gives them arthritis and long-term problems. Circular frame has got multiple advantages, versatile, excellent device. It has its problems. Patients don't like it, it's painful, it's uncomfortable, can't wear shoes, all kinds of problems. So to summarize, I think this circular frame is an excellent salvage device, very versatile, especially if you have infections, probably the best device available, very, very reliable, very consistent results. We have problems, we have failures, nothing is 100%, but excellent results. Leg lengthening is a challenge, especially in elderly, and you have to customize your plan for each patient and see what works for each patient. In the end, I would like to invite you to do our deformity course, which we do every year. It's in June every year. This year, the subspecialty is malalignment and knee complex, and you all are very welcome to come in. We also have a book. You can't buy this book, actually. You only can have it free. If you don't want it free, then you can't have it, I'm sorry. So you can go to the website, download it, and use it. Thank you very much.
Thank you, Prof. Sharma. Do we have any questions? Thank you very much.
Thank you.
Okay, after Prof gets a sip of water, he's going to continue on with his next talk. After that, we're going to have a lunch break and come back for the next session.
if you want.
Yeah, yeah, sorry. I'm hoping this will work. This is.
That doesn't work. But you can use this. No, wait. Where is the mouse? Where's the mouse?
Yeah, I know that. So.
You can use this.
Yeah. Right. So I have a little bit more time in this talk, so hopefully, and you will get bored and listening to me very soon. So I come from Hull. Hull is a city in north of England, in sort of middle of England on the east coast, and it's the part of Yorkshire, which is a lovely, beautiful country, green and lonely planet. Actually named it the top 3 in one of the top 3 places to visit in the world. So you're all very welcome to Yorkshire with the green meadows and lovely villages if you have any free time and you're coming in that part of the world. Hull is an old city established quite a while ago, and this is the church built in 1285. It's a beautiful architecture and the stone masonry. If you want to come, we had a lovely bridge, not as good as your Jabbar Bridge, but it's still nice, we think. And it's not as long, actually. It's very tiny compared to your bridge. It's nice. This is a hospital. It's a big hospital. We have a university, our own university, medical school. It's 1,500 beds in 2 sites. And we provide, it's a level 1 trauma center, and we provide everything across the board in a hospital established in 1782, so almost 250 years old at the minute. There was a chap in Hull called Thomas Smith. He started selling cod liver oil and bandages to hospital, and his business grew really well. And so what he asked was, he was struggling, so he asked his nephew that, can you come and help me do my business? And this is how the Smith nephew was born in Hull in 1896. I started in Hull, it's gone around the world, and Smith nephew now, the head office is Memphis, but the wound division is still in UK and Hull. So if you use any dressings by Smith nephew, they're made in Hull. So think of Hull, you do any Smith nephew dressings. The most famous son of Hull is William Wilberforce. He was a member of parliament, and he fought all his life against the slavery. And because of him, there are a few others, but principally because of him, the Slave Act was done, and ultimately British Empire stopped slavery completely, and he was one of the main characters for that to happening. Our unit, we cover a large area, cover a population of 1.4 million. We do a lot of research, some innovative research. One of our projects is to currently trying to give steroids in infections, also looking heat-seeking cameras to identify infections. We provide all spectrum of services in terms of lip reconstruction. We have 3 consultants, 2 of my colleagues, and we work as a nice team. We have 2 clinical fellows, nurse, physio, research nurse, 2 research fellows. This is our own unit within our department of orthopedics. So we run kind of semi-autonomous within the department. We have fellowships, 6 to 12 months. We have international fellow, which comes all across the world. Dr. Marwan and we worked together a little while ago, had a great time at that point. We have 1 fellow which we train for within the UK. We also have a visiting fellowships for 1 to 2 weeks and again, we get fellows across the world. And so you're very welcome to come in and visit us. I've been asked to talk about single versus stage treatment of bone infections. In this talk, we go through simple, a bit of basics, principles, and we talk about both the treatment options, and they would be intermingled into each other. They won't be not separate blocks. And as I always tell you the mistakes I have made and try to show you the problems I had, so hopefully it would be a nice experience, so you won't have to do that. You can learn from my mistakes. And we discuss some of the outcomes with that. So the difference between the 2-stage and the single stage is, in the 2-stage surgery, first stage, you do osteomyelitis, you do debridement, put some beads, absorbable, non-absorbable, give antibiotics, and then subsequently, 6 weeks later, you go stage 2, do another debridement, take more samples, and put in a bone graft. In single stage, you just do the first part. So patient doesn't have to go to surgery a second time, all that has happened. So it's either stage 1 or 2 stage, the principles are the same. So let's discuss the principles first, because then it will be more easier to apply in your day-to-day practice. Diagnosis can be challenging. If there is a pus, then you don't need anything. But if there is no pus, patient is in pain, there's a lesion in the X-ray, MRI, or PET scan, and then it becomes a bit of a problem because you don't know it's infection or not. There are a lot of tests which can help you, but nothing will confirm it. The gold standard is tissue sampling, which you can use for culture and sensitivities and use for histology. The problem with the tissue culture is only 60 to 70% is positive, even in the known cases of osteomyelitis. And why that happens? Because a lot of times we give preoperative antibiotics, there's a problem how we take the samples, then how do we analyze, store, transport, all the things which is beyond our control can affect the yield from the samples. But the technique is quite critical in it. So what we need to do is, we do not need to give antibiotics, ideally 2 weeks before the surgery for any tissue sampling, and that's included for arthroplasty infection as well. No antibiotics, and then take the sample, then you have a best chance of getting a yield. Your sample should be about 5 to 6. You must take from all across the wound, right? And how it works is, you need to have a separate set of instruments for each sample. You take a sample, keep the instruments separate, don't touch them until sampling is done. That way, you won't be the risk of cross-contamination would be fairly minimum. Then, what you don't need to do is take the swabs from the sinuses, the superficial samples, the biopsies, the aspirations, they're no good. They do not correlate what you get inside the wound, deep wound, therefore there's no point in correlating. Now in arthroplasty, sometimes you aspirate and things that is slightly different, but I'm talking about chronic osteomyelitis. If you have to aspirate a joint, give some local, if patient is not under anesthetic, make a tiny incision, about 2-3 millimeters, and put a needle through that incision. That way, the contamination of the needle from the skin is minimized. So your yield, what you get, is quite likely to be what you get inside from a joint or from the sample, if you have to aspirate. Ideally, I say, don't do it. So other thing what not used routinely is the histology. Now, histology is not a routine histology. You need to speak to a pathologist who are prepared to help you. And the idea would be, you take a sample from the same place where you take your culture, and when you look under a microscope, you need to look at it. For every high-powered field, there should be more than 5 neutrophils, right? If you have that, and so complete absence and presence actually correlates very well with the infection, even in the samples where the culture is negative, your histology can help. And in the combination of this, your diagnostic accuracy has increased significantly. So I urge you to take histology samples all the time and to make your diagnosis in combination. So take-home message from the diagnostic purposes, take 5 to 6 samples without any preoperative antibiotics from all across the wound. Every patient must have a histology sample, and don't mingle your instruments. Don't cross-contaminate. Once you have taken the sample, it should go immediately to the lab and inoculate it immediately. We must ring the lab and say that to the technician, I'm sending a sample, please put it in. If there is a delay, suppose you finish a case at 7 o'clock and nobody is in the path lab, then you can store the samples at 4 degrees until next day, but not longer than that, because then it becomes a problem. If you take any fluid, always put it in the blood culture bottles, because that gives you best yield. Those blood culture bottles, because the way the whole system is designed, you can keep them at the room temperature, and that improves your yield. So preoperative preparation is the part of surgery. Surgery alone will not give you the results unless preoperatively we prepare these patients well. Our approach should be a team approach. In my team, apart from orthopedic surgeon, we have a plastic surgeon, infectious diseases, and a radiologist. We have MDTs, clinics, and we work together as a team. Because what you need is a single-stop decision-making. You get all the scans, all the information, patients come, you sit down together, make a decision, plan, and go ahead. The multiple appointments, the multiple problems is an issue because your scans get old. Then you worry about, do we need to repeat the scans? So single-stop decision-making process is ideal. If you have a team approach, it's better for the patient. Your outcomes are better, and your rate of recurrence and your hospital stay is less. Patient go home early, which is the aim. Nobody likes hospitals. Everybody wants to go home with the family to the familiar circumstances, and that's what we need to do. So take-home message is that all bone infections should be dealt in a team approach. Then let's look at the classifications. Cherney-Meder classification is the most common classification, which divides into 4 types of the anatomical region. And then there's a physiological part of it that is the host good. Is the host compromised systemically or locally? Or host is so bad that it's not worth operating because patient might die and you won't get the required results. How is host compromised? These are the systemic and local things which will suggest that your host is compromised in a way. And the classification comes with the clinical staging. You do physiological and anatomical classification and come to a certain number which will tell you what kind of host this is physiologically and where the anatomical problem is. And that works actually quite good. Recently, Oxford, Martin McNally's group came out with this BACS classification and again is looking at things in a slightly different way. So my take-home message that the classification can be helpful. Is helpful to plan your treatment and overall management, and therefore we shouldn't kill ourselves and take the right classification. That's not the aim. The aim is that the classification, if we know enough information, it will guide us towards our treatment. In principle, there are only 5 things you need to do. You need to debride properly. When you debride, there'll be space. How do you fill that space? Is the bone stable? Because unstable bone does not heal heals very slowly and that increases infection, so the stability needs to be there. And do you have a good quality tissue which will deliver the blood to the site? If not, then you need plastics. And you need to give antibiotics. So the question comes in, who will do the debridement? So if you look at the previous speakers, if you have to do a complex acetabulum, you really don't want me to do it. You want somebody who does it every day needs to do it, right? So similarly for tumors, then it's the same token, the infection work should be done by somebody who does infection work all the time. It's not anybody who's not interested, because the guy who does the infection work will do it properly. So when you do the debridement, soft tissue generally is not a problem. Sometimes you do it with plastics, it's not an issue. The issue comes in how much bone do we excise? Because there's a lot of it's a dead bone, there's a granulation tissue. So I'll tell you a story. So when I was young, I was just in my last year of training, I was on call and I got this chap and I was really excited, and I said, I took the patient to theater in the evening, debrided, closed it, put a plate, and I thought, fantastic, what a good job I've done. And this is the problem of having the job in the same hospital where you are trained. And this patient comes to me. It's my first case of osteomyelitis within the first year of my job. And this is the discharging sinus. So in those days, I said, yep, fantastic. What I do, I always do. I take a segmental excision, put everything in the bin, put a corticotomy, lengthen it, it heals. Happy. So this was my standard practice when I was young, right? Cut transport, beautiful, right? But then in time, we have learned that I don't think we need to excise that much. We need to do not need to do this radical tumor-like resection anymore. And if you look at the history, we have learned a lot from the history. It started from a long time ago that what do we do, then came out from there, and until we slowly moved on to 1993, where Martin McNally published his technique from the Belfast as a two-stage technique and said, radical debridement of all infected bones. And if they don't bleed, you go back again and take out some more. So keep on debriding until you get a bleeding bone. And what we used to call is a paprika sign, a punctate bleeding. So all dead bone must go. That is the current practice. But sometimes it's not possible to excise all dead bone. So this is a humerus, and this is the extent of lesion. I'm not going to take this humerus out. There is no way I can do that. So all I have to do is, I have to make a long trough, clean it out, put some Stimulon pellets into it, and just close the wound. I can't take this humerus, so I cannot take all dead bone out. And this is post-op, and this is a year down the line. And most of the times, actually, if you look at it, you don't have to take it out. So this is an example where this lady had a plateau fracture 6 years ago, had initially fixated, came back with this discharging pus and a large cavity in the femur. You do your MR, CTs, and you look at it, there's a large area. And a lot of people will do a segmental excision for this and transport the femur. What I did was I just made a channel and just cleaned it out, put some lot of Stimulon beads, and just closed the wound. And this is a 5 year down the line. So what is the problem? Problem we think is a dead bone, but we need to differentiate from the sequestrum. Sequestrum is loose dead bone. Attached dead bone is dead bone, but is not sequestrum. We must remove the sequestrum. Then there's infected granulation tissue and there's bacteria. So planktonic is easy to deal, but the main problem is the biofilm. And what happens is that you'll ask any revision surgeon, has any revision surgeon ever looked for the paprika sign? Never. They don't. They just clean it and they have enough space, clean, ream, impact, and just put another stem. And do it all. Had anybody looked at the paprika sign in their stabulum? They don't. So why we have to look for the paprika sign? Because I don't think it is necessary. So the rationale for taking all dead bone out is there is no blood supply, so blood can't reach there to kill the bacteria. So if you look at it, how much blood you need to take that biofilm out. The amount of antibiotic you need to kill that level is so high that you cannot provide it either systemically or by locally. There's no chance any blood supply will deliver enough antibiotic in that region to give you that of minimum inhibitory concentration. So if we can't achieve that, then we are losing the first argument. So the question is that if can't deliver the local antibiotic from the blood supply, then is there any point to taking all this out? So if dead bone doesn't have blood supply where they reach the bone, if you look at the same argument, if the blood can't reach there, then bacteria can't reach there either, because bacteria also needs a channel. Once you have cleaned the dead bone out, what you see, blood can't reach, antibiotic can't reach, so bacteria can't reach, because there is no other way for bacteria to reach that point without the blood supply. So the problem is not the dead bone. It is a problem, but not in the way we look at it. Problem is the biofilm, which is a main problem. So if the problem is the granulation tissue and the biofilm, then we must focus on thorough debridement rather than excising all dead bone. Our focus should be a thorough, proper debridement. Take your time, as much as you like, wash, clean, whatever you need to do. And this is my standard practice. I create a trough. If it's more than 10 centimeters, I go slightly smaller because of risk of fracture. But if it is shorter, I go up to 10 millimeters and then clean the bone out and just fill it in with the local antibiotics. And I get all the high delivery of antibiotic at that point by giving the local antibiotics. So we looked at the recent results, and we published it last year, end of second half, and we looked at our results from adequate debridement, not radical debridement, all done single stage, and we found we have a 90% resolution of symptoms, which is not too bad. Other problem is that if you take too much bone out, then there's a risk of fracture, which is a 5 to 10%. So luckily, we haven't had any fracture. We'll have one day, we all will have. But luckily, up till now, it hasn't happened. But there's a risk of fracture. We need to be ensured that there's no fracture, because if there's a fracture, it's an added significant problem. And if you have a fracture, and if you're not sure, just put an X-fix, post-op, do a CT, X-rays, and then look at it, and then decide. That you can do, because the fracture is a problem. So the question is, how do bacteria survive? Why do we get recurrences? So the new concepts coming out, there are 4 things we need to look at. One is these colonies, these abscesses which we have, right? So these are like an abscess of Staph aureus. Then you had a biofilm, which is through the implant. Then you have a Staph aureus in the bone, into the canaliculi, and Staph aureus in the neutrophils. And if there's a neutrophil, they can hide and travel. That's the problem. You look at it. So debridement is crucial because antibiotics can't reach any of these places. So the only solution is debridement and disruption and taking everything out. Unless we do that, we cannot get any a good outcome. The other thing recently is coming out is the migration, the invagination of the canaliculi network. And what happens is that, for some strange reason, the Staph aureus goes into the canaliculi and reside there. And it's hard to see, because we would know if it is there. And it's not just near the bone. What it also does is, it goes round really close and then goes into the deep and sits sometimes quite deep inside, actually, in a distant osteocytes. So that can be a problem. The clinical relevance hasn't been fully established as yet, but I think a lot of work is going on for us to understand, and this is an ongoing work, and hopefully we'll have to change the way we see things in time. So my take-home message is that radical debridement for every case is not necessary. In some cases you have to do it, but numbers are very tiny. In most of the cases, adequate debridement is sufficient to give you the optimum outcome. So once you've created this space, what do we do about this space? And this is a nice story. This is a Dutch soldier. He thought, we need to have this space, we need to fill it with something. So he took a dog and filled this bone in a soldier. The church got so upset, they said it's a heretical against religion. So the poor guy has to go back and take all the dog's bone out to satisfy the church. And otherwise probably would have been killed or hanged or something like that. So so that historically was the first one who realized. And then slowly we changed our practice, learned, and we found that the 2-stage solution is good, where you clean it out and put the bone graft, and they do pretty well, actually, right? Because one of the biggest concerns is that despite extensive debridement, have we left any microorganism behind? Because they're so small, we can't see them, right? There's no way to see them, and that might be a risk of recurrence. And again, I come back to the biofilm. It is quite critical that we do not let biofilm mature. And if biofilm has matured, there's a bit of a time between the infection and your surgery, then it is a mature biofilm, and the debridement is the only option. So what is available for us? You have non-absorbable options like a standard cement. You have, again, bioglass, which is there. There's some antibiotics loaded allografts are there. But most commonly used is the calcium sulfate, which is quite commonly used and has good results. And you can use the biological methods, and I'll show you an example of that, because we use that intermittently. So let's go through first the biological solution. So there's an osteomyelitis. In most of the units, this chap will have a segmental excision. What we did was we just made a small hole. Hole was slightly bigger, the plastic surgeon, because we have to put in a flap into it and then put in a drain inside it. Because what we do is we put a a free flap. So this is a gracilis going into the bone. And what we do is we put a negative suction for 7 days to keep the flap inside the cavity. Then there's an edema of the flap, so that fills the cavity. And what that does is that delivers the antibiotics locally. And then what happens is that, and then you leave it, take the drain out in a week. This is a year down the line. This is another case in a distal tibia, which we did again, osteomyelitis, put in a free flap. This is 1 year down the line. So this is we use from time to time. We used to do a lot more before the calcium sulfate came out as a local antibiotic. We do much less now. Calcium sulfate appears to be the ideal delivery system. It's got very good compatibility. It dissolves, and which means we don't have to go back in, and which means there is no substrate for the bugs to stick and to cause any recurrence. There is some suggestion that it regenerates the bone. I'm not too convinced about it that it does. And there are a number of products available in the market, and the elution time varies how much time they take to dissolve fully. One of the biggest problems with the calcium sulfate is the wound drainage. And between up to 15 to 20% is not unknown, and normally you don't need to worry about it. You need to be careful. Patient worries, we need to warn the patient that there would be leakage, and the reason for that is that it dissolves and it comes out, and this is what. And I think one of the things is the reason we believe is that if it's a subcutaneous, it leaks more. So the airtight closure, which was talked about earlier, is quite useful. Sometimes sealing the wound is useful, so that don't leak, they still leak. Luckily, there's no suggestion at this point that they cause increased risk of infection, because I think the antibiotic local concentration of MIC is massive in that area, and so elution is long, so that helps. So calcium sulfate seems to be the most commonly used antibiotic carrier, probably the best what we have in terms of use, whichever set you want to use. There's enough evidence for Ceramide G, Stimulan. These two we use the most, and also the Osteocet T, whichever one is available, is quite useful. The biggest advantage of this is of Stimulan and Osteocet is that you can mix the antibiotics you want rather than pre-packed antibiotics like in Ceramide. Then there's a Bioglass. And Bioglass works very differently. It's actually a sort of, it's a dead piece of sea coral kind of thing. And what it does, it works in two ways. One, it releases the sodium ions. What it does is it increases the pH. So pH goes to about 11 or so. And then what happens is that it also forms it changes the osmolality, and the combination of these two techniques inhibits the bacteria. In some cases, they suggest that is bactericidal as well. But these are the two factors it works. It doesn't have any antibiotics in it. And what it does is, then it forms a silica gel, and then because of that silica gel, it forms a natural hydroxyapatite, and what it does is, once it forms that, it forms a layer, and it gels with the bone, so forms basically sort of becomes the part of the bone. And that is the reason it says that it works very well. My experience is not that extensive in it. I've used it. My slight worry with that is a bit of a glass. And if you're working near the vessels and it leaks out, then it worries me slightly. But people have used it and it's come out with very good results. Scandinavia particularly have got very good results. Then the question comes in, why do we get the recurrence? Is it the surgery we haven't done it properly? Is the antibiotics? But I think it's the combination of things. There's a reason it happens. But the colonization of OCLN may be a part of it as well, which we don't understand, which may learn about it, and that's maybe one of the reasons. The other thing is the antibiotics. So how long do we give antibiotics? There is some belief in some quarters that you give longer IV antibiotics, it works better. Actually, that's not true. Oxford, this is Oviva trial, and they found that shorter antibiotic is not inferior to the longer IV antibiotics. And since then trial, what we have used is, we have gone to 1 week of IV and 5 weeks of oral. That's a pretty standard. So patients stay in hospital for 1 week and then go home and then give 6 weeks of in total IV antibiotics, which we hopefully will bring it down in time as well. And what it does is, patients goes home, it's much more cost effective, and it is much cheaper for any healthcare system. Duration, nobody knows how long it should be. We currently give 4 to 6 weeks, 6 weeks, and there is no evidence that 6 weeks is better than 4 or 12. However, is the current standard practice, good results, so we continue with that. Solario trial has just finished. They have completed the recruitment. I think it's about 455 or 500 patients, and I think by next year, end of next year, we have the results to which will tell us is that in combination with local antibiotics, if we have used either for arthroplasty or for osteomyelitis, do we give shorter antibiotics duration? And I'm pretty hopeful, I don't know, I'm not the part of the trial, I was just part of one of the centers recruiting, that we will end up with the shorter antibiotics. And some of the things we have changed, like arthroplasty, we don't give post-operative antibiotics anymore. We give a single dose at induction, and we don't give any post-operative antibiotics. Actually, for any elective surgery, we don't give any post-op antibiotics now. And because I think longer antibiotics does not change any difference, it is the induction, that's what the evidence is coming out slowly. So my take-home message for these is that for most of the, almost all your infections, apart from polymicrobial, some resistant infections, keep them out. For all your day-to-day infections, which are most of them, 1 week of IV and 5 weeks of oral should be the standard at this time. By next year, I hope the duration will come down as well, but we don't know, we look at the trial. We looked at the one-stage systematic review, and we found that the literature suggests about 86–97% of the control rate. There's another study came out from US a while ago, and they found that 1-stage and 2-stage are similar. The only difference is that 2-stage has more procedures, and that's because of the removal of the beads. And if you take this out, there's no difference. If you look at the outcome of the data, what is available in the literature, this is a lot of units. We did some work, the scoping review, then we have some work from Oxford and other places, and they all are suggesting that you got a decent outcomes even with the single-stage osteomyelitis. We're just about to finish a systematic review. The data collection and analysis is complete, and out of that, there was 1,600 patients. 1 stage is 91% control, and stage 2 is 89%, 2 stages 89% control, and it seems to be the similar result. These are the 2 guys working with me. Well, actually, they are doing most of the work, actually. I'm just saying, hi, that looks fine. But these 2 guys, Ali Lari, I think you took the initiative, and these are 2 guys working. They have done all the work. I'll just put my picture because I'm giving the talk, that's all. So the work is, which we hopefully should be publishing this very soon. And the only thing we found in the single stage is prolonged leakage, increased wound problem. That's because of the leakage, but there's no suggestion in literature that increases the risk of infection. So what's my current practice? This is our protocol. We preoperatively optimize the patient and try to improve the physiological status if we can, diabetes, smoking, those kind of things. We do not give any antibiotics 2 weeks, 3 weeks prior to the surgery. If it's elective, if it's an emergency, we don't have a choice in the sense somebody is unwell, pouring pus kind of thing. But generally, if it's elective, we sometimes postpone the surgery to have 2 weeks of clear antibiotic-free period. At induction, no antibiotics, multiple samples. We have a separate sampling tray in which use arthroplasty surgeon and we use, and the picture I showed you earlier, multiple samples. We take the histology, and then once we have taken the samples, we give broad spectrum antibiotics until the culture comes. And then a pretty standard is 1 week of IV and 5 weeks of oral. I always put, after debridement, I put local antibiotics. I use more Stimulan. My colleague Ross uses a more Ceramide, but we use for different things, indications. But all our surgery, pretty much most of them are single stage, unless we have planned a 2-stage for a reason. all a single stage surgery. So let's go back to my first case, what we did. If I have to do this case now, I will just do a local debridement, put some Stimulan or into it. I will not do a segmental excision. I will not do a dead bone excision. I will not look for a paprika sign. And I'm 90% sure that he'll do fine. So what is better? Your outcomes are similar. Complications are similar. From patient's perspective, they have to come to hospital once for single surgery. There's less morbidity, much cheaper for them if they're paying from their pocket. So it makes sense that the cost must be cheaper because you don't come to the hospital twice, you don't go to theater twice. So what is the cost? This is the UK cost. Theater costs about £1,200 an hour. Bed in my hospital costs £250 a day. So if you have to come twice, the second time you're saving all this money for your hospital, and you can operate a second case in that time, right? Which is even better. Therefore, my suggestion would be that single stage management of chronic osteomyelitis should be the standard of care in all scenarios, unless you have planned a two-stage surgery, in which case you have to do two-stage surgery. Otherwise, the standard of care is a single stage management of chronic osteomyelitis. So to summarize, I said single stage should be the care. Adequate, thorough debridement is important, not radical debridement. But this has to be done with the local application of antibiotics, because local antibiotics are key, and that can be delivered by any of the calcium sulfates. And I use Stimulan, and there's enough evidence to suggest that up to 6 weeks, I can get above MIC level of antibiotics locally where I've worked. Team approach works best. Not only they give you ideas, they tell you don't be stupid, don't do that, right? Because they're friends, you work with them, and from patient's perspective, it's fantastic. Patient comes once, everybody sees him, gives them an opinion, advice, you make a plan, go ahead and operate. Our infectious disease consultant, Dr. Barlow, he even writes a post-operative antibiotic letter. So he tells you in an electronic system, you go in, there's a letter from him saying, if you using Stimulan, use this antibiotic. If you post-operatively give this, so we don't have to even think about it, what we have to give. He has already done it. 1 week of antibiotics is enough in almost all cases. Very rarely you have to go more in polymicrobial, or sometimes you have resistance, or sometimes you don't have an oral option, in which case it's something different, but for most cases, that is enough. Thank you so much.
Thank you, Prof. Any questions?
Thank you, Professor, for this talk. Actually, it's changing our mind, the way we look to infection now, because we thought always of a segmental involvement of the bone with the cortex involved and the medullary, you have to do a segmental resection. That's the only way. So the cases you showed, the cortices were involved, right?
Yes.
Not only the medullary canal.
Yes.
Okay. So that makes us think like a dentist. If we see a cavity in the tooth, deossorize the cortex, clean it up, fill it with antibiotic, and preserve the rest of the tooth, right? That's the way we look at it now.
Yes, I completely agree. I think if we look at it, we felt that dead bone will propagate infection. But if you look at infection is only superficial on the dead bone. It cannot go inside the bone. If it's inside the bone, we can't see. So if you take the superficial cleaning out by 3, 4, 5 millimeters, you've taken all the infection out. And this is how I see it, like you see it.
But sometimes the medulla is closed because of chronicity of the infection. There is no medulla. It's like it's a whole block of bone. How do you approach these cases?
So if you have a closed medulla, then you have to find where's the cavity, because there will always be a cavity, because your cortical bone can only harbor the infection on the surface. So either there's an involucrum and there's a multiple cavities, in which case you have to have an extensive channel and do multiple cavity clean out. But all dead bone will only harbor the bacteria on the surface. Now, is there a possibility that you have so many cavities and so much that you cannot do all that? Yes, you can, in which case segmental excision is not unreasonable. So I'm not saying that it cannot happen, but the instances are pretty rare. But most of the times in a clinical practice, we find there's a 1 or 2 cavities, or maybe 3 cavities, which you can go approach and clean it out.
Thank you.
Thank you for the talk. I just have a question here in mind. So it was a very interesting lecture. Actually, this debate is...
Can you bring it slightly closer?
It's
Thanks.
a very interesting lecture. This debate actually happens a lot in our department, whether to do a single or two-staged. You covered some aspect. I don't think this is applicable to Kuwait. One is costs, and most of the plastic done here in Kuwait is done for citizenships, and they don't pay anything.
Sorry, I couldn't understand that bit.
So in Kuwait, arthroplasty surgeries and revisions are free for the citizens, and that's most of the patients we see. Another issue is the IV antibiotics. We have an issue with antibiotics here in Kuwait. Our stewardship is very bad. Most of our patients who come with infections are resistant to many microorganisms, and most of those antibiotics given is IV. So the standard practice has become in Kuwait is IV antibiotic. I understand oral is better and you can discharge the patient, but sadly that doesn't apply here. You said it's rare, maybe in the UK, but here in Kuwait, that's definitely not rare. That's what you see in most practice.
So can I answer this first? Otherwise, I'll forget. I can't remember things.
Okay.
Is that okay? So I think we all change. If I look my practice 15 years ago, we didn't have antibiotic stewardship, right? But in time we changed, we learned, we evolved and changed our practice. And I think that's true for all of us. And I'm sure that with time, antibiotic stewardship comes in and people will start believing in things. You have like-minded colleagues and things will change. So, and this is where the collaboration and interaction comes in. So, for example, Gavin Barlow, who works with us in infectious diseases, he does a worldwide antibiotic stewardship actually, right? And there's a possibility we can have a whole antibiotic stewardship for actually all hospitals in Kuwait, not just yours. And that way, it will help, because I think the evolution is important, because if we evolve, it's better for the patients. And I think this is the principal reason we need to change. Cost-wise, I don't think these are as expensive. I think in Africa, Southeast Asia, South America probably is more challenging. I think Kuwait is probably much easier to use a lot of these things once they are available.
So if it's free, they will abuse it. That's a standard human practice. So the stewardship will not change here in Kuwait. Okay. And you said in your practice, if you do single stage, you're 90% sure that you will give the patient, you get rid of the infection. So patient satisfaction here in Kuwait is always expected to be high. They will not accept 90%. So if 2-stage will give them 91, they will take 91. They will not accept 90.
So that is the thing. If you look at the systematic review, which will be published by the Kuwaiti trainees, so that would be a good paper to say, actually, 2 stages 89, 1 stage is 91. So I think we are in a winner.
Okay, hopefully. So another issue we have, many of the infection cases we're getting are actually coming late. They're not coming where you can give them a grace period of 2 weeks without antibiotics. Many of them are coming actually from private hospitals where antibiotics already started. So in our department, it's not like a policy. What I've seen now, the standard practice in our department is if the patient comes to you, we can do a single stage if you know the organism, or you can easily identify the organism. But in most cases where they came from private hospitals where already antibiotic has been started, or the patient is already septic or admitted for another medical issues, which is something common happens. He's coming with a chest infection, urinary tract infection, and then goes the periprosthetic infection. We cannot do that. The standard practice should be the 2-stage for him.
Actually, our practice is exactly same as yours. We do not take any acute infections. We refuse because we cannot cope. So our system is, I take from the regional hospital like you take from private hospitals, other places. We get all late infections. If somebody comes with the antibiotics systematically, I'll stop the antibiotics. They do not, chronic osteomyelitis do not need antibiotics. They just need a dressing to cover the wound, that's all. It does not need antibiotics. We stop all antibiotics. So you can do the same, stop the antibiotics, and then treat them like all our infections I've shown you, all our result, our work is all late. We do not accept early infections. We said, sort out yourself, abscess, whatever, we're not interested. We only take chronic late infections. So you can do exactly the same as my practice.
Thank you.
Thank you very much, Prof. I'd like to...
Thank you. Just a comment, sorry, not a question. Badr, please, he trained me, all right? If anyone, don't feel that you're in a separate institution in Kuwait, okay? If you have any complex case with an infection, you don't have to refer to me, just call. Just call. Just share, we can share opinion. You can take my opinion, you cannot take it, it's up to you. I can come help you for any case, not you, for everyone, all right? Any bone infection case, I am willing, I'm offering my service, all right? If you have any problem, if you have any problem, please call me, all right? I will give you advice. If there is any need to take over the case, I will take over the case. If there is any need to come and help you in the case, I am very happy to do this. But please do not start any treatment. If you want me to be involved, for anyone, do not start any treatment before talking to me, if you want me to be involved, all right? If you start antibiotics or do any surgery and things go suboptimal, I cannot salvage much, you know? So please involve me early, and I'm more than happy to help, okay?
Dr. Marwan, I'm afraid that you might feel sorry for this offer.
No, I enjoy these cases.
I think I have that feeling as well.
You're going to be overwhelmed.
Okay, I'd like to present Dr. Ouaid Lamtairi, who's going to be awarding the speakers for this session.
Can I ask one more question? Dr. Sharma? Yeah.
Yes.
What antibiotics do you mix with the stimulant?
So because we don't have any samples, we don't do preoperative sampling, so we put generally vancomycin and topramycin powder, which is broad spectrum, and or vancomycin or gentamicin.
Or vancomycin and gentamicin.
So we give broad spectrum. So our idea is that we don't have to mix the specific antibiotics. We start with broad spectrum antibiotic cement, broad spectrum antibiotics post-sampling, and then in 48 hours you will know, 48 to 72 hours, what is growing, and then you can change accordingly.
I see. Because one of the issues here is we have MDR, which is a multi-drug resistant bacteria. So if you do that approach, will you consider a second stage to do another debridement and change the local antibiotics, or you just consider it with the IV antibiotic and the antibiotic regimen?
So if you look at it, if your antibiotic concentration is high enough, even the resistance bacteria can be killed. We know that. So the question then comes in that, and sometimes if you see, arthroplasty surgeons has for decades used gentamicin in the cement. And even the bugs is not sensitive to gentamicin, still it works. I don't know why. So I think if the debridement is good, you have broad spectrum antibiotics, and you've got a systemic antibiotics, then I don't think you need to go and do a second stage unless there is a clinical issue. So our practice is that we don't have that problem for multi-drug resistance at the minute, but if you have multi-drug resistance, and then you will know clinically. Now there is some new work is coming out where you can do, what happens is that hopefully in a few years it will come out, that some of these Staph aureus secrete antibody, and you can take out that antibody and then measure that. That will tell you the resistance, whether your antibody is working or not, all that. So that's called Mensa. That will come out in a few years, hopefully. So at the minute we don't have anything, but at the minute rather than definitely going second debridement, I would suggest do a clinical assessment. And the best example is, there's a paper from, I think, Kalala from US. They put 755 patients for revision and used a Stimulan. And what they did was, everybody over 5 days of leakage, they took them back to theater and washed it out. But I don't think you need to do that. Sorry, can't hear you. So selective micro. Sorry, my
Cortical drilling.
Okay.
Just I imagine if selective cortical micro drilling could be an addition to one-stage treatment of chronic osteomyelitis, if it could tackle bacterial colonization.
The problem with the selective microdrilling is that you are creating another space if you have any bacteria left behind to go in that hole, because they can go in that hole, and there would be an element of dead space unless you put calcium sulfate into it or something else into it. So the problem is that bacteria do not go in the cortical bone. So in my view, drilling will not add anything to it, because bacteria are not inside the bone, they are on the surface.
Okay.
Okay, thank you very much. We will not be taking any more questions. Next, I'd like to present Dr. Uaid Lamtari, who's going to be giving an award to Professor Sharma. Thank you very much for coming, Prof.
Thank you so much. Thank you. Thank you for having me.
Thank you, Prof. It has been a pleasure.
Thank you so much for the honor and the privilege. Thank you.
Thank you. Next is going to be Dr. Majid Shaheen. Thank you, Majid, for your contribution. And next, Dr. Thnayan Al-Amiri. Thank you, Dr. Thnayan. We're going to adjourn the session for 1:30. 1:30, please.